So what we're gonna review this morning is the mitral inflow, the mitral annular velocity, the pulmonary vein flow, and then we're gonna go into diastolic dysfunction and the grading of diastolic dysfunction. Gonna stress the importance of LA volume and how it's measured. We're not going to discuss color and mode flow propagation velocity because it's not used at the present time for the assessment of diastolic dysfunction. So again, when we say diastole, diastole is the period of the cardiac cycle when the heart is being filled with blood. Okay, so you have relaxation and filling of the ventricle. You need to know the Wiggers diagram. Basically, the Wiggers diagram is a combination of a lot of stuff. Okay, at the bottom you have what we call the phonocardiogram, which is the sound, the heart sound. So when you see phono, it means sound. So we know the first heart sound is due to closure of the mitral valve. Second heart sound is due to closure of the aortic valve. The period between the closure of the mitral valve and the closure of the aortic valve is systole, right? The period between closure of the mitral valve and closure of the aortic valve is systole. And the period between closure of the aortic valve and the mitral valve is diastole. You can see that systole is in a normal heartbeat, normal heart rate. Systole is a shorter period than diastole. So with a normal heart rate, the diastolic period or interval is larger than or greater than the systolic interval. The faster the heart rate, however, diastole becomes shorter and shorter and shorter. Okay, so you have to appreciate that. This is your electrocardiogram. Systole is from the onset of the QRS to the end of the T wave, and diastole is from the end of the T wave to the QRS. Okay, of course, you know your P wave, QRS, T wave, and so forth and so on. This is the ventricular volume. You know that in diastole, which is from the end of the T wave to the QRS, the ventricle is filled with blood. So the volume in the ventricle goes up. And then in systole, when the ventricle pumps the blood out, the volume falls. Okay? This bright blue line is the LV, was the ventricular volume. This is the ventricular volume, okay? Sorry, ventricular pressure. Sorry, ventricular pressure. This one is ventricular volume, ventricular pressure. So in diastole, the pressure in the LV is relatively low, but when you have contraction, when the ventricle contracts, the pressure goes up, okay? It goes up to a peak, and this is the systolic pressure. Then it comes down to another, we'll call this the diastolic pressure. The aortic pressure is a bit different. The diastolic aortic pressure does not fall to the level that the ventricular pressure falls, or the left ventricular pressure falls. So you can see that the diastolic aortic pressure is a higher number. So this is the aortic pressure waveform, where in diastole it has a certain number. In systole it goes up to about the same number as the LV pressure, and then in diastole it falls. So you need to know these different curves and waveforms. It's just help you to put things together. And then the atrial pressure. So in diastole, the atrial pressure mimics the LV pressure. Okay, in systole, the atrium is still filled with blood. So when we talk about systole and diastole, is ventricular systole and diastole. So again, in systole, when the left the ventricle contracts, you still have blood flowing into the atrium. If you're talking about the left side, then blood is flowing from the pulmonary veins into the left atrium, and in diastole it does the same. The only time you have blood flowing backwards is when the atrium contracts. So this is the Wiggers diagram. Go over it, study it, know it. All right, so when we look at the mitral inflow, we talk about the IVRT, which is the isovolumic relaxation time. It is a period between when the aortic valve closes, just before the mitral valve opens, so the mitral valve is still closed. So all the valves are closed. The E velocity or the E wave is the passive early filling of the left ventricle, okay? And then we talk about diastasis, which is the period between the early passive filling and the late active filling. That's a period between the E and the A wave or velocity. The A velocity is active late filling. It's active because it requires energy. So it's an active late filling of the left ventricle due to the atrial contraction. So the atrium contracts to give you your A velocity. So this is a diagram I drew to give some sort of clarity. Look it over, and that is how it's done. So you can see this is your apical four-chamber view. This is the cursor. The sample volume is placed at the tip of the mitral leaflet, okay? And when you press your PW button, you get your LVOT flow, the IVRT, your E wave, diastasis, your A wave, and your IVCT, okay? So that basically depicts what we have been saying. And this is how it actually looks. Four-chamber view, cursor, sample volume, and when you press your PW, okay, your ECG is on top, so you can see that mitral inflow is a diastolic phenomenon. So you get your E wave, your A wave, so your LVOT flow would be somewhere right here, and then your IVRT would be right there. To get the deceleration time, it is from peak E to the baseline, and sometimes we measure A duration, that is the duration of the A wave. In a normal young individual, the E wave is greater than the A wave. The deceleration time is less than 250 milliseconds, and your IVRT is usually between 60 to 90 milliseconds. So you have to know the normal numbers, okay? So again, your deceleration time, so this portion will be the acceleration where it goes up, deceleration where it goes down. We commonly measure deceleration time because it gives us an insight into diastolic function and dysfunction. Again, deceleration time is time from the maximum E velocity to the baseline, or from peak E to baseline. Tissue Doppler imaging is very important when we're doing diastolic assessment. It is obtained by placing the sample volume at the medial mitral annulus and the lateral mitral annulus, both. You're going to use pulse wave Doppler. It's a pulse wave Doppler measurement. So four-chamber view is on top. The mitral annulus is here, medial mitral annulus. You get your S prime because the base of the heart moves up towards the apex. So you get your S prime. In diastole, you get an early diastolic wave and a late diastolic wave. The early diastolic wave we call the E prime. Late diastolic wave we call the A prime. Again, these are the mitral annular velocity tissue Doppler imaging. The same thing, S prime or the S wave. The S prime wave is the systolic annulus velocity, how fast the base of the heart moves up, the speed, okay? All right, so S prime. Your E prime is the early diastolic annulus velocity, and your A prime is the late diastolic annulus velocity. It's very important to recognize that your E prime reflects relaxation of the myocardium. So the myocardium relaxes in diastole to fill with blood. So your E prime reflects relaxation of the myocardium. It is reduced in patients with impaired relaxation. So when a patient have diastolic dysfunction, the E prime is the earliest, one of the earliest parameter to be affected. Okay, so a decrease in E prime is one of the earliest marker of diastolic dysfunction. Okay, it tells you that there's impairment in myocardial relaxation. Okay, again, we mentioned that EE prime tell you about the filling pressures. Okay, when someone goes into heart failure, one of the earliest thing that happen is because and let's just look at the left side of the heart. One of the earliest thing to happen is increase in the left ventricular filling pressures, that increase in the LV diastolic pressure and hence the left atrial pressure. Okay, that's one of the earliest thing to occur. And your EE prime ratio, if it's greater than 15, it it tells you that you have an increase in your left ventricular filling pressure and left atrial pressure. So your EE prime greater than 15, and we're talking about the medial E prime. EE prime greater than 15 suggests pulmonary capillary wedge pressure greater than 20, hence elevated end diastolic pressure. Now, when you say pulmonary capillary wedge pressure, it is a surrogate of LV filling pressure or left atrial pressure because of how we measure it. You know, to measure the left atrial pressure directly, we'd have to puncture the atrial septum and put our catheter into the left atrium and then measure that pressure directly. That's pretty invasive and extensive to do that. We can measure what we call the pulmonary capillary wedge pressure, and it gives us a very close measure of the left atrial pressure. If you remember your anatomy, when we go into the pulmonary trunk divides into a right and left main pulmonary artery, and then it branches out and you get arterioles, and then it goes into capillary, and then the capillary is all over the lungs. It penetrates the lungs, and then the capillaries after the lung, once you're breathing and you're breathing oxygen, then the capillaries is gonna get oxygen, and then these little blood vessels coalesce to form the pulmonary veins, which drains into the left atrium. So if we stick our catheter way out there, if we stick our catheter into the capillaries, we can actually measure the pressure that the pulmonary veins are seeing. And remember, the pulmonary veins drain into the left atrium, so we can actually measure the left atrial pressure. Okay, and that's what we call pulmonary capillary wedge pressure. It's a surrogate of the left atrial pressure and left ventricular end diastolic pressure. All right, so if it's greater than 20, it suggests that it's elevated, and the EE prime ratio greater than 15 give us that information without doing anything invasive. A EE prime ratio less than 8 correlates with a normal pressure in the left ventricle, okay, and left atrium. So if it's less than 8, it suggests that the pressure in the left atrium and left ventricle in diastole is normal. All right. Pulmonary vein flow. So again, when we do the pulmonary vein flow, you have your apical four-chamber view on top, and you have your right lower pulmonary vein there, and the left over this side. If you just put this is the cursor sample volume just in the pulmonary vein, okay, you get something looking like this. You get a systolic component and a diastolic component, and then an atrial flow reversal. ECG is on top. So with the pulmonary vein flow, you get a systolic component and a diastolic component. The worse the diastolic dysfunction, that is the greater the diastolic dysfunction, the systolic component gets less and less. In a normal individual, the systolic component is a little bit larger than the diastolic component. The greater the diastolic dysfunction, the systolic component gets smaller and smaller. Okay, this is your atrial flow reversal right there. Okay, so just imagine, just picture, this is the left atrium. The pulmonary veins drain into the left atrium. There are 4 pulmonary veins, 2 on the right, 2 on the left. You have upper and lower, and the pulmonary veins drain into the left atrium. But when the atrium contracts, it's going to force the blood in the opposite direction. So this is your transducer. So from your Doppler lecture, you know that flow towards the transducer is going to be above the baseline. So the pulmonary blood flow, pulmonary vein flow is from the pulmonary veins into the left atrium, and it's moving towards the transducer, so it's above the baseline. You get a systolic component and a diastolic component. But when the atrium contracts, it's going to force the blood in the opposite direction, away from the transducer. That's why it's below the baseline. The atrial flow reversal is below the baseline. All right. Again, so we talk the pulmonary vein velocities. All of these things are pulse wave Doppler assessment. The S means systolic wave, diastolic wave, atrial flow reversal. As we pointed out in our last lecture, the greater the diastolic dysfunction, the greater the left atrial pressure. So someone with grade 1 diastolic dysfunction have less left atrial pressure than someone who have grade 2 or grade 3. So the greater the grade of the diastolic dysfunction, the greater the left atrial pressure. And you can sort of think about it. If you have a left ventricle that is not relaxing properly, or you have a left ventricle which is stiff, it's going to put pressure backwards. So the atrium, or the left atrium, is going to see greater pressures. The worse the impairment of relaxation, or the worse, the stiffer the ventricle becomes. Okay, it's going to be difficult to expand the ventricles, and so the pressure is going to increase. All right, so the reason why we talk about diastolic dysfunction is because heart failure, when we talk about heart failure, it's customary to refer to systolic dysfunction, ejection fraction 30%. So, we quickly understand that that patient will develop heart failure, but you can develop heart failure and your systolic function is normal, but you have diastolic dysfunction, impairment in diastolic function. What we have realized is that 50% of all patients who have heart failure have diastolic dysfunction or diastolic heart failure. That is, their ejection fraction is normal, but there's impairment in the diastolic function, or they have diastolic dysfunction. So it's important to recognize that, okay? So diastolic heart failure accounts for approximately 50% of heart failure cases, and its prevalence is increasing with age. So as one gets older, the percentage of diastolic heart failure gets greater and greater. Okay, the grading of diastolic dysfunction can help in management strategy, because we said that the greater the stage of the diastolic dysfunction, the worse the condition is. Okay, so the higher grading suggests worsening left atrial pressure and left ventricle filling pressure. All right, so as mentioned before, when we talk about grade 1, so this is an old grading system. There, we don't talk about a grade 4. So listen to me carefully. You know, even though it's a grade 1 to 4, it's grade 1 to 3. So that was the old system. Now the current system, we talk about a grade 1 to 3. With grade 1, you have a problem with relaxation. You have abnormal relaxation. And when you look at your E to A ratio, the E is smaller than the A, and it's usually less than 0.8. When you look at the deceleration time, it's usually greater than 200 milliseconds. When you look at your IVRT, it's usually greater or equal to 100 milliseconds. Your E prime is usually less than 8 or 7 centimeters per second. You cannot have diastolic dysfunction unless your E prime is less than 8 or 7 centimeters per second. Okay? And your EE prime ratio is usually 8 or less. Okay? Because EE prime ratio tells us about the left ventricular filling pressures or the left atrial pressures. If this is greater than 15, then you shouldn't have a grade 1. You're going to probably move into a grade 2 or something like that. And then when you look at your pulmonary vein flow, you have a predominant systolic component. That the systolic component is greater than the diastolic component. So that is your grade 1 diastolic dysfunction. If you remember what we said in the last session, your grade 2, so this is your grade 1 diastolic dysfunction. This is what it actually looks like. When you do your mitral inflow, your E is smaller than the A, okay? When you look at your pulmonary vein flow, your systolic component is greater than the diastolic component, and the atrial flow reversal is about normal. When you look at your tissue Doppler, your mitral annular velocity, your E prime is going to be less than 8 or 7 centimeters per second. So this is classic grade 1 diastolic dysfunction. When we talk about grade 2 diastolic dysfunction, you now get into a greater stage where there is impairment in relaxation, and you might have some problem with compliance. Okay, it is pseudo normal. So the E is bigger than the A. Okay, E is bigger than the A. Your E prime, because for you to have diastolic dysfunction, the E prime have to be less than 8 or 7 centimeters per second. You're going to have increased left atrial volume index, and the number to remember is 34 mLs per meter square. And then we talk about the TR velocity. The number to remember is 2.8 meters per second. So if your TR velocity is greater than 2.8 meters per second, then it satisfies the criteria for grade 2 diastolic dysfunction. Again, this is pseudo-normal. Okay, the E is usually bigger than the A. It looks normal. That's why they call it pseudo-normal. It looks normal, but it is not normal. And you're going to have E prime less than 8 or 7 centimeters per second. You're also going to have EE prime ratio greater than 15, EE prime ratio greater than 15, because now you start having increase in your left atrial pressure, you're increasing your left ventricular end diastolic pressure, left ventricular filling pressures. Those pressures are going to increase. So your EE prime ratio is going to be greater than 15. So again, so when you look at your mitral inflow, E bigger than the A, so you may think it's normal. So you may think this is normal, but when you look at your tissue Doppler imaging or your mitral annular flow, the E prime is less than 8 or 7 centimeters per second. So it can't be normal. E prime less than 7 or 8 centimeters per second. And then when you look at your pulmonary vein flow, the systolic component is much smaller than the diastolic component. You have atrial fluid reversal. So this is grade 2 pseudo-normal, and then grade 3 and 4, well, again, there's no grade 4. So when we talk about grade 3, these are very sick patients. They have diastolic dysfunction, very sick. The first thing that you're going to see when you do your E to A ratio, E to A ratio, so the mitral inflow, when you look at your mitral inflow, you do your E to A ratio, that's going to be greater than 2. And then the next thing to do is look at your E prime. If your E prime is less than 7 or 8 centimeters per second, you need to look at nothing else. That's grade 3 diastolic dysfunction, and we say that these patients have a restrictive filling, filling pattern. Okay, there's problem now with compliance. The heart is non-compliant. Okay, so it's grade 3 diastolic dysfunction. The E to A ratio, mitral inflow, sorry, the E to A ratio, mitral inflow greater than 2, E prime small, less than 7 or 8 centimeters per second, deceleration time less than 160 milliseconds, IVRT less than or equal to 60 milliseconds, and then you're going to have very large left atrial pressures. And again, remember surrogate for left atrial pressure, EE prime ratio greater than 15, telling you that you have increase in left atrial pressure. The left atrial volume is also going to be increased, left atrial volume index. So the number to remember is 34. So when you do your left atrial volume index, you're going to get a value greater than 34 mLs per meter squared. And then your pulmonary vein flow, you get predominant diastolic flow. So this systolic component is much less than the diastolic component. So when you look at your mitral inflow, big E, small a, big E, small a. When you do the ratio, it is more than 2. When you do a tissue Doppler, E prime is very small. That's, you need to do nothing more. But remember that your left atrial pressure is going to be increased. Left atrial pressure, EE prime ratio tells us about that. That's going to be greater than 15. Left atrial volume is going to be increased. So that's going to be greater than 34 mLs per meter squared. Your TR velocity, which tells you about the pulmonary pressures, that is going to be greater than 2.8 meters per second. So this is the grading system for your diastolic dysfunction. I'm going to stop here, and on Tuesday we're going to wrap up. On Monday we're going to wrap up our assessment of diastolic dysfunction.